Thank you, Antonio, for teaching us on the this new device, new stent, this bioadapter, and we want to hear from your experience during this case. So maybe we can go to the cath lab, and we have all our panel members here. I'd like to just quickly introduce, besides Antonio, Dr. Nok Kwang from Hanoi, Donnie Furman from Jakarta, of course, my co-chair, Adrian Lau from NUH, Ramesh, head of cardiology at KL, and not least, Professor Bao from the All India Institute in Delhi. Welcome, and let's quickly go to the live case at the Heart Center's cath lab. And Lim Soo Teik and Woon, you are online as well as Edu.
Hi, Prof. Can you see us? Can you hear us, Prof?
Yes, yes.
Yeah, Prof Ko and friends and colleagues. Yeah.
Yes.
Thank you. Yeah. Good evening. Yeah. We have this. We have prepared this case. What looked like a relatively straightforward case, but a lot of discussion point. We have a young patient, a 37-year-old gentleman who had dyslipidemia, diabetes, newly diagnosed diabetes, and a family history of premature coronary artery disease, and non-smoker. Admitted in November last year with a non-STEMI and angio found to have a triple vessel disease, and the culprit proximal to mid RCA was stented already, and the ejection fraction was normal. The lab tests were all normal, and perhaps we can show the. Sorry, I can't see the. Yes. Okay, so that is angiogram during that procedure. Yeah, and that was before RCA, and then there is after. And left-hand side, the mid LAD has 75% narrowing, 60 to 75% narrowing. And then after the OM1, there is also another 80% narrowing in a relatively small branch. So the target lesion for this session is the LAD. And perhaps we can show what we find today, the angio today, and then we'd like to consult our colleagues what best to do. Yeah, and this is we just check the right coronary artery, and then we have this angio. The angio look quite similar to the previous angio in November. Yeah, the AP cranial, and then so this is the OCT run, the pre-PCI OCT run, yeah. And perhaps Dr. Pham want to make a comment? No, yeah. Sorry, Dr. Pham is not mic up, yeah. So maybe we show the OCT. Kevin, you want to make something? Yeah.
So this is OCT that we have done with co-registration. We were distal to the tightest portion in the mid-LAD. So you can see that the disease is actually quite diffuse in the LAD. Beyond where we started even, he has diabetes. The distal reference lumen was about 2.1, 2.2. And proximal, we have a size mismatch in excess of 3 millimeter. Okay, this is after the balloon dilatation. So here we are faced with this problem of diffuse LAD disease. We don't have very much normal segment where we did the initial OCT run. So we had the second OCT run that was a little bit more distal and hope to find a relatively more healthy segment. So maybe you can show the next one, the later run. Yeah, so this is the more diffuse. So you can see from the co-registration, we actually place the marker more distally, trying to look for a relatively healthy segment to implant the stent. The longest bioadapter that we have is 38 millimeter, but it looks longer than what the available stents we have, and we may have to overlap two bioadapter in this case. So it's both an issue of length, excessive length, as well as a proximal to distal size mismatch. So maybe I could pose the panelists. Should we try with just one stent, the 38 millimeters, trying to go across the diagonal, or should we go for a two-stent strategy?
Maybe we also want to show the ostium, the diagonal, the run. The ostium diagonal run.
We did a pullback from the diagonal as well.
Yeah.
So this is pulling back from the diagonal. So the plan was to cross over the diagonal.
Yeah, not too much disease at the ostium or the diagonal. Yeah. But the disease segment involves slightly across the bifurcation. So the plan is actually to stand from proximal LAD to the mid LAD, but the land is actually close to the upper limit of the land of this bioadapter.
The concern is if once we cross over the diagonal, if there was anything that compromised the diagonal, we may need to perform a port in the proximal LAD. Even using the 38 millimeter stent, we may not have enough length to adequately do a port with the shortest 8 millimeter balloon that we have. So any experience with overlapping two bioadapters so far for those who have this stent available?
Maybe you can ask Dr. Colombo. He probably has the most experience with this device.
Okay, first of all, I do not believe that you have to cover with any DS from normal to normal, especially when you treat diffuse disease. If you take this approach, you're going to implant very long stents and risk to go to full metal jacket. I believe, and this does not apply to bioadapter, applies to any DS. You need to treat the critical lesion. And then if you have some lesion more distally, you treat only if there is a dissection, which is a bad dissection, not a generic dissection, or if the disease is critical. Otherwise, if you pretend to treat all the disease, you end up in implanting too many long stents, which is not. So I will go to implant not a very long stent, reevaluate, do the OCT after implanting the stent, and see if you really need another stent or if you can leave it as it is. Be aware that the cure for diffuse disease is not a stent. The cure of diffuse disease is medical therapy.
Adrian has a lot of experience with IFR, FFR. Maybe, Adrian, you think doing that might help? Adrian?
Yeah, I think that's excellent points here. The other concerns that I have is with using the long stents is what is the expansion limit? Because given that the stent is held together by polymer I'm not sure how forgivable it is with going to, with a larger sized balloons, and especially when there is such a size mismatch. I think maybe using the physiology may help in deciding where you have the highest gradient, and that might help you to limit the number of stents that's used. And I just attended your session on IFR, and I'm not sure whether this might be a situation where that would be useful in guiding the focal spot stenting.
Yeah, Adrian, thanks for the suggestion. Yeah, but it's a little bit too late to do that now. Because we are pre-dilated. While waiting to go on air, we have actually pre-dilated this one. So our discussed strategy, because we are thinking of that, as mentioned, to stand from the proximal to the mid LAD, covering that long disease segment, but with a tighter segment just above the second and the third or fourth septal artery. But then it is at the close to about 38 millimeter.
Sure.
Yeah. So the option is to either implant one 2.5 times 38 millimeter bioadaptor and then post-dilate. According to even though the IFU for this 2.5 bioadaptor specify the expansion of 0.5 millimeter above the stated dimension, but the bench testing showed that this at 2.5, the bioadaptor integrity is maintained up to 4 millimeter of the expansion, whereas the 3.5 with the 8 crown per ring can go up to 4.5. 2.25, 2.5, 2.75, and 3 all can go up to 4 millimeter according to the bench testing. So so that is a concern. So the second so at 38 there's a little bit concern about the port when we want to do that, and the other option is to actually do the overlap stent 2.5 at 28, and then we overlap a 3 millimeter bioadaptor from proximal to mid. So those are the two options that we were thinking about. We didn't do the IFR test. Yes.
An option that we utilize when you treat long lesion, especially in the LAD, is to implant a stent relatively short and treat the rest of the vessel with a drug-coated balloon, evaluating the final result with PDPA, pressure gradients, and FFR. This is a way to limit the stent length, preserve side branches, and be safe, because if you measure the residual pressure gradient and the fractional flow reserve, you have some guarantee against early occlusion.
Yes, thanks, Antonio. So we did the balloon dilatation, 2.5. This is the 2.5 non-compliant balloon, yeah. And this is the result that we get angiographically. So there's some dissection, yeah, in the mid LAD, and we did another IVUS run after that. Timmy, can we show?
We're switching to the OCT run after the dilatation.
The last one, I think, yeah.
Again, you can see the co-registration. We were distal to the tightest part coming back. Disease diffusely in the LED. So this is where the tightest portion is. Mainly fibrous.
Very short segment with some calcium, yeah. Not too much, yeah.
Here we can see the dissection.
Yeah.
And we're coming to the diagonal. Yeah, here's the diagonal branch coming in. And proximal.
Yeah. So with that, probably we will need to cover the whole length. Yeah, any other, any suggestion from the panel?
Soo Teik, are you planning to cover just to back to the ostium of the diagonal? I don't see much plugged just proximal to your diagonal, right? So there might be an appropriate landing zone just distal to your, from your diagonal down to your tightest spot. That might limit the stent length.
Yeah, so just stand it right at the ostium, you mean? At the bifurcation, the carina.
The ostium is disease-free.
Yeah. So there's another option that we try to place it exactly right at after the bifurcation.
Yes.
Yeah.
But there's a little bit of
You
disease.
have your OCT, you can measure the length, right?
Yeah.
Yeah.
We do see disease just immediately after the diagonal,
Yeah.
so we probably will need to cover over the diagonal to adequately cover,
Yes.
which means it will cross over the diagonal.
Yeah, here. No.
Yeah. And down here it looks relatively disease-free.
Yeah.
Then you don't have to
That will
stand all the
come
way
out.
back proximally.
38.
The just opposite to the carina, just opposite to the carina. A little bit not too diseased, but it's right at the ostium.
33.
Yeah.
So
Yeah.
we need a 38.
So that's about 33. We'll need
Yeah.
about 38.
38.
There's one option.
It's
Yeah.
either 32 or 38.
Is that the okay? If that's the case, then we will
2538.
implant the 2538. Yeah.
2538.
What do you think of the size of the vessel distally?
Yeah.
Can you take a 3
Yeah.
hole instead of 2.5?
I think the stent is
from
2.75 might be better for the distal.
Yeah, the original, the lumen, the original, the original actually the lumen diameter was about 2.25, and then the EEL, the vessel diameter is about 3.2. Yeah.
I think you can
Go
use a
with the 2.
3 stent. Only thing is, if you land it just below the bifurcation, that might actually hasten the proximal in-segment restenosis. So I'm not sure whether I probably will land it way lower than the diagonal. I won't actually cover.
2538.
Yeah, 2538.
2538.
So we will plant 2538 and then we post dilate lah. Yeah. Just to be safe. Yeah.
Do you think there is a
So we can focus
sort of a
on the
mild
stents.
myocardial bridge segment at the distal stenosis or not?
Further distally,
Everybody can see the
Right
stents
where
against
the
the gauze.
text-
I think it looks like any any normal stents, even
we
intravascularly.
can't tell
Yeah.
the myocardial bridging from the OCT very well. Yeah. So this
There's
one,
one question
the
from
bioadapter look very much like the.
Okay, so we selected the 2538 bioadapter, the DynamX.
Maybe you can ask. Let's go to the AP cranial then.
So stent front delivery is.
If you had to overlap, is there special techniques to overlap, like absorb some edge to edge, or you overlap? How you overlap?
Let's go to test here.
Yeah, I think the. You think the. So
Colombo,
according to the instruction.
We never overlapped these devices,
yeah,
but I don't think you have to use
the
any special technique, minimal overlap, like any stent.
Just have to ask him.
Like absorb, they used to say that you just have to very minimal and
minimal overlap, like always.
Okay.
If you pull back, that will give us another. You want to see just.
Let's see.
So we'll position the stent just after the diagonal. So this is where it covers distally if we play this run. This is versus if we pull back a little bit more proximal. Probably will still cover the tightest portion.
The other initial, one of the other thought that I have, I just may want to check with Dr. Colombo. Do you think we can use a Sabo technique to try to precisely position this at the ostium? Entry point into the mid LED. Yeah, let's take one picture.
Okay, right.
I think you can see angiographically reasonably well.
Yeah. What do you think?
Yeah.
Shall we just pull back and see if we just cover
This one we covered it.
Concern of not
pull back a little bit.
stenting across the diagonal is for what reason?
Inadequate length before in the proximal LED for port if the diagonal does compromise.
Yeah. Looking at it, maybe we may have just slightly enough length. Yeah. Huh?
I think we should. Shall we try?
Yeah, maybe what we'll do is this. Just how when we measured, the small.
Okay,
Yeah.
just here. Right.
Yeah.
Okay, let's do the same.
Yeah. When we measured earlier, it is at the upper limit of the.
So we just covered the tightest part. Proximally, we are beyond the diagonal. 8 millimeters, just cutting it if we do need the port.
Yeah, we're stretching the limit a little bit. Yeah. So maybe we deploy here. We deploy here. Yeah.
Okay, we'll go to nominal.
Yeah.
Nominal 10. We're at 10.
So the deployment, the implantation technique is exactly the same as the metallic DES for this bioadapter.
Go a little bit higher.
No, I think we will use that. Let's take a picture.
Sure.
Okay. So the side branch, the flow is good. The ostium looks all right, and then it seems to just cover it. So we are going to do a post dilatation with the non-compliant balloon, the distally.
So post dilate with a 3O non-compliant balloon. 50,
And
yeah.
yeah. We go a little bit RAO, and then and prepare the short 3.5, long 8 millimeter. Yeah, yeah.
NC.
Let's do a prepare
3.5,
for the stem
8,
boost.
3.5.
Stem boost. Yeah. More RAO. Yeah, more RAO. Yeah. Okay. This what balloon?
This one, 3015 NC Sapphire 2.
Okay, let's not stick out. Yeah. Let's do a stem boost.
Cool,
Yeah.
stem boost.
It's too far.
Well.
Yeah. One more stem boost, huh? Yeah. Let's go to 12 here. 12.
18, 24, 12.
So it's the same 6-cell stem platform across from 225 to 30 and a 8-crown stem platform for the 3.5 stents.
Down.
So the concern of the size mismatch proximally, there is bench testing to suggest that even for the stem platform of 6 crowns, we can go up to 4 millimeters.
16.
16, yeah. Save, yeah.
Down.
We'll wait for 15 seconds. Yeah. Okay, okay. Yeah, all right, yeah. Back to the
Professor Bao, is this available in India? This bioadapter?
Then we should use the let's
do a stem boost with proximal edge.
Yeah. Prepare the balloon. Yeah. Don't go too high. Don't go too high.
Okay.
Let's stem boost here and see. Oh no, too far.
Yeah.
Too far. Yeah.
Yes, about there.
The stent stroke, the bioadapter stroke is only about 71 micron, yeah, and with the coating of 6 plus 3 micron, yeah. Let's go up here. Let's go to just 14.
You think?
Yeah.
14?
Yeah. Let's prepare the
short. Yeah.
The short, yeah, 3, 5, yeah, down. This one go to the LAO plane, yeah, and see. Let's move a little bit. Yeah. Okay, yeah. So we are going to do the pot, and
what pressure you went up to?
16 for the trio.
You think you should maybe any of the panel would just consider doing the OCT first, and if it's well opposed, you may not need to go up further.
Geographically, that's
you mean
the OCT evaluation is probably one a good consideration now.
Do you want to do a proximal optimization first?
You can do that before the OCT. Since
Huh?
I think with
Yeah,
angiography, you cannot evaluate a position.
Yeah. Sorry, Dr. Colombo, you mentioned doing the OCT first?
No, I think I will do routine post-dilatation, maybe not super aggressive, but I think in the interest of time, to do a post-dilatation and then do OCT. And then if necessary, after OCT, you may do or may not do another post-dilatation, but most of the time, a first post-dilatation is almost routine. Not routine, but almost.
Yeah. Yeah. We don't intend to be too aggressive.
He post-dilated with a NC balloon already.
Yeah. Yeah, it's a little bit far out still. Yeah.
We don't have anything shorter than a.
Yeah, unfortunately,
balloon.
The shortest is actually 8 millimeter. Yeah. Okay, there's this one. Yeah. I will just go in a little bit and then we go. Yeah, let's go up here.
Yeah.
Let's go up here. Just 12.
So there's a 358 NC balloon that's inflated.
The lateral thing. Okay. Yeah, down. Let's get the OCT catheter in and then do an injection plus the OCT at the same time. Yeah. So we just plan to do the provisional and then what is if the side branch remain good, we don't intend to do the kissing balloon dilatation here. But what is the opinion of the panel?
Maybe Kwang, you want to have some comment?
I think if the flow is diagonal is okay, and then I leave alone. And if I really want to protect the diagonal, and then we will use the jelly balloon technique to protect the diagonal. But however, we already put the stent crossover, so we just see by the OCT, and if the flow is diagonal is okay, and then I finish the case.
Ramesh? You agree?
Yeah, I agree.
Ready or not?
Calibrate.
Huh? I do a test. The test. It's okay. Yeah, engage. Huh? Yeah.
Okay.
Okay.
Okay, we're ready.
Yeah. You're enable pullback. Yes, move a little bit.
Maybe you can project the OCT image. Yeah. I'll stand close to Jian so that he can give his expert opinion on the OCT.
Yeah, so can you all hear me? This is the final post-procedure pullback, showing that the stent is well opposed. And just going from distal. And looking for any signs of edge dissection, which is quite particular because the whole area is diffusely diseased. Don't see any signs of dissection here. Stent is well opposed, And we actually have the opposition indicator as well to show that it's actually, there's no signs of malopposition here. Reasonably expanded. And the proximal edge actually looks quite alright as well. No signs. So it's quite well expanded, and no signs of dissection as well.
What is the what do the panel think?
I think it's very nice results that you have there.
Criteria of adequately expanded stent.
You think we can just in the what is the minimum implant area, the minimum bioadapter device area? Where is
3.7?
No, where is it? 3%? What do
Sorry, is it
what do you think?
5.7 or something like that, right?
That means you have the fly through and see.
Expansion index should hit at least 80 to 90% for optimal expansion. So in this case, I think both the distal expansion and the proximal expansion, this does hit the criteria of at least exceeding 80%. In fact, actually exceeded 90%. So it looks well expanded at both the distal and the proximal edge.
Going to do the fly through? Yeah.
So take you got about 3 minutes or less.
Okay.
Before we conclude. Maybe one last final shot without the wires.
Yeah.
We're trying to give you the fly-through view as well from the OCT. You won't be able to see the uncaging elements, unfortunately. Yeah. You have on screen the fly-through view. Yeah. Timmy on top. True.
Yeah, actually, on the appearance like that, it does look like the appearance of a metallic DES. So this is just a fly-through view showing again the stent from inside out, from inside the coronary lumen.
It looked very much like the usual metallic. We are not able to tell actually exactly the uncaging element. Which is located at the low stress area along the sinusoidal ring, near to the sinusoidal ring. And then, newly implanted stent, we are also not able to demonstrate that pulsatility. This one we need to wait until it get uncaged.
When will that happen?
Yeah, usually about 6 months. The novolumers will be eluted within 3 months, and then the bioresorbable polymer will get resolved after 6 months, and that will happen. And then the element will get, the bioadapter will get uncaged, and then maintaining the ability for positive vessel remodeling, and also the improved vessel conformability to the curvature. And also it allows some pulsatility and improvement in the vessel physiology. And we think that it will be helpful for let's take a picture.
I can ask Professor Colombo, there are some questions that the audience has asked. What is the recommendation for using DynamX in bifurcation and calcified lesions at this time?
I think it's the same as metastent. You need to prepare the lesion well. You need to post-dilate, exactly the same. There is no, you can do kissing balloon, you can do double stent. Of course, we have no experience about the crash or the cool-off, so that's the reason why we would like to push the company to do at least a prospective registry of this device in complex lesion. And the key is to do a 2 years follow-up. I would love to see the OCT after 2 years, to see if after 2 years you have a positive remodeling. This will be the key answer to all efforts to do a change. If you don't see positive remodeling, then it's a waste of time. But you need to collect at least 100 patients with complex lesions, because of course, not every patient will behave the same.
Thank you. So Soo Teik, maybe you quickly summarize your conclusions and maybe give a very short answer to how long the DAPT will be for this stent.
So the original study used 1 year, yeah, and but we don't have a shorter DAPT, yeah, but the original study using 1 year. But I suppose that we can also use a 6 months DAPT, even though the clinical experience with this bioadapter is still fairly limited at this stage of the product development, like what Dr. Antonio mentioned. Yeah, perhaps we can treat this more like a metallic DES at the acute phase, and hopefully the benefit for a longer term, yeah, can be realized. So the 2 years data that Dr. Antonio Colombo presented is of great interest, and then a bigger data series will be very helpful. Yeah.
Okay, thank you very much.
Today we demonstrated the yeah.
Go ahead. Yeah.
Sorry. Yeah, today we demonstrated that the acute implantation of the bioadapter is very much similar to the metallic DES, and no special precaution, and then you will, unlike the BRS with the pure polymer platform, and the technique is exactly the same. It is very deliverable, it is quite conformable, and then knowing the expansion limit will also allow us to treat it more like the metallic DES. Yeah. And if the side branch is compromised, we are actually prepared to do the kissing with a short overlap, and then do another port just like the normal DES. Yeah. And we hope that long term it will translate to clinical benefit for this very young patient after it engaged. Thank you very much for the opportunity to share this new exciting product. Yeah, thank you.
I'd like to thank the whole team, Soo Teik, Woon, and Edu, and the Cath Lab people for this nice demonstration of a relatively new device and a long stent implantation done well. No issues, and the OCT shows a very nice result. I'd like to actually thank Antonio Colombo for taking time to deliver the lecture and also contribute tremendously to this discussion. Of course, my co-chair, Adrian Lau, and all the panel members for their contributions. So I'd like to say thank you all for attending SingLIVE 2021 online. It's been a great pleasure and a great honor for all of you to be able to participate with us. Hope to see you in person next year. Stay safe, stay healthy. Bye.
Bye-bye. Thank you.
Bye-bye. Bye-bye. Thank you.
Thank you.